Good morning. We're on our last week of the Cardi-OH clinic, Your Patient with Diabetes at Risk for Heart Disease, a series of case discussions. I'll go ahead and just pass it off to Dr. Rao and we'll get started.
Yeah, thank you, Jesse. And thanks to everyone for joining us for this series. I think it's been a lot of fun. I've certainly learned a lot myself throughout it. So the last session has a twofold purpose. First of all, we have a couple of presentations and a couple of really interesting presentations and cases from Grace and Mohammed. But beyond that, we also wanted to address a few loose ends. So, I've been doing echo for a long time, and there's nothing worse than having an issue that you think is really important, that you need in order to address with your patients, and it's just not addressed in the series. So we try to solicit feedback about what may be missing. So in that context, there's a couple things we wanted to talk about. First, I'm going to turn things over to Kathleen. The issue of distinguishing type 1 and type 2 diabetes has come up, I think, almost every week in some context or the other, or at least every other week. So she's going to give us a short presentation, and I'm going to tie up a few loose ends after she's done. So Kathleen, take it away.
All right, we can go to we did come up with a few objectives, so you can see those here. So I just wanted to review, first of all, I think everyone knows basically what the difference between type 1 and type 2 diabetes, but sometimes where it gets a little fuzzy is those in-between zones, which we sometimes call LADA, or latent autoimmune diabetes in the adult. There can be a lot of overlap. And sometimes if it boils down to, if you just have suspicion that it's worth going ahead and testing for type 1 diabetes, and we'll talk about what is actually recommended as far as testing. But note that in general, the younger the patient, by far that's the most important determinant. But if you have a patient who's just really difficult to control, needing insulin very soon after diagnosis, presenting with extreme hyperglycemia, probably doesn't have a strong family history of diabetes, and very also important, if they are somewhat lean, that you should be thinking about LADA. On the other hand, on the far right there is MODY, or maturity onset diabetes of youth, or monogenic diabetes is another more broader term. These, by sort of convention, are people who all have a strong family history, autosomal dominant pattern of diabetes. They are diagnosed at a younger age, and they tend to be lean. They have a normal C-peptide. And so the key here is that they have negative autoantibodies. And these patients are important to identify for a number of reasons, but I won't get into that. But some of that has to do with treatment decisions. This is just a little bit more information. So LADA is a term that we use, we throw around. You might even find a diagnosis code in your EMR, but it's technically not really a diagnosis by itself. There's some controversy among expert groups whether we should just call people LADA or just call them type 1 diabetes, which is really what I think is a nicer way to describe it, is slowly evolving immune-mediated diabetes. And generally they're a little bit older. And the key is that we miss it a lot. So of people who are eventually diagnosed with type 1 diabetes as an adult, 40% of them are initially treated as though they have type 2 diabetes. So that slows down the progression, so that slows down the appropriateness of treatment. And we have evidence that these people are more likely to develop complications long-term. And so this is a recently published statement by the EASD, the European Association, and the American Diabetes Association that kind of helps walk you through this. So in here I have strong risk factors. So particularly age under 35 is the strongest by far risk factor. And then the weaker risk factors. And so if you think about those stronger risk factors, those are people especially that you could think about going ahead and testing for type 1 diabetes. And on the algorithm here, what you do is you get autoantibodies. In general, the GAD antibody is the initial antibody. If that's negative, then you can go on to test other autoantibodies. And if the antibody's positive, then you can stop there. That's type 1 diabetes. If it's normal or negative, then look at their age. Then if they're over 35, they really have an unclear classification. So you follow down that right hand pathway. You can consider what is their, what is the overall balance of risk factors. You might trial non-insulin therapies. And importantly, these are people that you might need to check a C-peptide periodically to see if it's declining. So note that about 5 to 10% of people who have type 1 diabetes don't have any autoantibodies. And then if they're under age 35, consider whether they might have features of monogenic diabetes. So, and if so, then go ahead and do a C-peptide. If the C-peptide is normal, then you can send for genetic testing. If it's not, then you're going to classify as type 1 diabetes. If there aren't other features of monogenic diabetes, but there are features of type 2, you could consider, again, non-insulin therapies. And otherwise, otherwise you're going to treat as type 1. Next, and oh, I'm sorry. So just note, looking at these numbers here, the lab assays are different at different institutions. So I just put a reminder there. At our lab, our normal C-peptide is somewhere around 0.4 nanomoles, and in this case, they have it's written in picomoles. And then finally, I would just highlight, once you do have a C-peptide, what do you do with it? And there is a consensus statement that was published actually in the last year that kind of helps to spell this out. Make sure that the glucose is obtained concurrently with the C-peptide, because the C-peptide is only is best interpreted with the glucose between 80 and 180. And if the C-peptide is low, less than 0.3 nanomoles per liter, you treat it as type 1. If it's greater than 0.7, you treat it as type 2. And with the knowledge that you might need to recheck periodically. And then if it's in that no man's land, then you probably need some combination of insulin plus non-insulin therapies, and then some periodic monitoring of C-peptide to see which direction the patient's going to go. And in particular, there are a few other caveats for people who have this slowly progressive autoimmune diabetes. There's some evidence that sulfonylureas cause fail more quickly and may possibly accelerate the loss of beta cell function. So it's suggested to avoid those. If the patient is lean, be very, very cautious with SGLT2 inhibitors because of the risk of DKA, or make sure that they're also on insulin to help kind of minimize that risk. And then if their A1C is particularly high, really think about going to insulin sooner than later. And that's all I have.
Thank you, Kathleen. Any questions? Just a question for Kathleen. In the adolescent world, when you have a patient presenting with diabetes, not in DKA, the general principle is start insulin, get them under control, and then worry about whether they're type 1 or type 2 later on. That's kind of just like, get them controlled, get them feeling a little bit better. Would you advocate that in adults as well? Because we see a lot of primary care docs trying to figure this out. Should I do this? Should I do that? But insulin sometimes is a good initial choice. And of course, you can take it away later on as well.
Yes, I agree with that. It really depends upon the presentation. And if their A1C is particularly high, or they've got extreme or severe hyperglycemia, then insulin's the way to go until you've sorted it out. And then you can always backtrack later on.
Okay, thank you, Kathleen. So there were a couple of other points that had come up in our last survey. One was a pretty minor point about when do you get direct LDL values? And it was actually my case, I think, in which the LDL cholesterol was reported as 10 milligrams per deciliter, which seems unrealistic. And the reason it's unrealistic is because that's a calculated LDL. There's the Friedwell equation, which has now been called into question, but it's total cholesterol minus HDL minus the triglycerides over 5. So if your triglycerides are very high, your LDL is going to be artificially low. So normally that gives you a good estimate of LDL. But if your triglycerides are 400 or above, it's not valid. And you need to measure the LDL directly, which is much more expensive, time consuming, and not available in many laboratories. Now, some laboratories, if they have it available, will automatically do a direct LDL if the triglycerides are high. So the circumstance, I think, in which you would choose to get a direct LDL is if you suspect that the LDL you're getting is not genuine, and you want to make sure the lipids are controlled. So they have, type 2 diabetes that's not under control, or they have other risk factors for heart disease. It's reasonable to ask for a direct LDL. The last point I think was a really important one. It's just a huge issue. And that is, how do we accomplish all that we're supposed to do as primary care physicians in the space of a 30-minute diabetes checkup, for example? And it really is. I mean, even the annual foot exam can, by the time they get their socks and shoes off and they're ready to go, and it is really time consuming. And I think that there's many ways that have been tried. There is the Diabetes Navigator in Epic, which we were studying this back in Chicago, and only 7% of primary care physicians regularly use the Diabetes Navigator. I never used it. It was 3 pages of things you had to do and discuss, and it just went on and on and on forever and ever. Then there is the clinical decision support idea, prompts, best practice alerts that come to physicians through the electronic health record. Shouldn't your patient be getting a flu shot? It's like, and then of course, a lot of those are prone to alert fatigue. People tend to turn them off. They get very annoyed with them. And of course, there's a context for that. Maybe the patient doesn't want a flu shot. You didn't have time to record the refusal. So those things don't work. When I started practice, people used to mail guidelines to you in the mail, and they would stuff your mailbox full of those. And that has zero impact. That's why the Agency for Healthcare Research and Quality stopped investing in guidelines. So I wouldn't say it had a little impact, it had no impact whatsoever. So within my own research and our team, we are approaching this from a different angle. And that actually has a lot to do with the principles of shared decision-making, patient-centered care, social and racial justice as well. So I strongly believe that everyone, no matter who they are, where they live, what their background is entitled to the highest quality care. And it's difficult to get it sometimes. Part of it is issues of access, and part of it is simply the workflow and the way our healthcare system is structured. I think it's possible to be in a disease management program, or to send someone to Karen, for example. Karen would probably know what's missing in this person's care. However, that's not always possible for everyone. Not everyone can go to an endocrinologist, et cetera. So I just wanted to share the empowerment checklist that we developed. See if I can share this with you guys. Can you guys see this? Okay. So the idea is that this checklist is given to patients prior to their appointment. Services are not necessarily delivered to patients because the physician is not interested or not motivated. It's often because they have to set priorities in terms of a diabetes visit. And quite often for me, to be honest, the priority is simply trying to get their diabetes under control. Yes, I need to make a referral for an ophthalmologist so they can get their retinopathy screening, but boy, is that further down the list, because they had one last year and I know it's annual, but I want to defer it just a little bit, or I need to do lipids, or I need to check the urine. But there's sometimes other things. So these are 10 questions that we want patients to ask us. And of course, this sort of prompting and empowerment does work. I've often said this in ECHO and in other sessions, the most powerful tool that I have ever developed in the pediatric hypertension world is simply a sign in a waiting room that says, ask your doctor about your child's blood pressure. Better than any clinical decision support or or the echo program in pediatric hypertension, which is of course a lot more work. So these are things, has your doctor told you that your diabetes is not under control? What have they talked to you about in terms of changing medications? What happens if it's out of control? Have they discussed your blood pressure, cholesterol, diet, smoking, urine, eyes, and a flu shot? Now, we added 2 questions to this at the urging of Kurt Stange, who is in my department, and those relate to another measure he developed. Does your doctor know who the most important people in your life are? And are you generally, how do you feel about your care in general? So we've changed the questionnaire slightly. So I think this is I hope to say that it's a little bit of a promising approach. It's a different approach than what we have seen. Oh, sorry, I'm going to stop sharing if I can. Let me go back here. Maybe that'll work. There it is. It's a promising approach, I believe. Let's try that. And I think that it's something that is more likely to have an effect than the traditional approaches that we have tried now for 25 or 30 years with minimal success. I sit on the National Quality Forum's Primary Care Quality Measures Committee, which reports the CMS. And that committee reviews new measures that are put forth by different groups, such as National Committee on Quality Assurance, et cetera. And I can tell you that incentive-based measures, which essentially what these quality measures are, also have relatively small impact, and only while the incentive is really top of mind for people. So I think we'll stop there. And if there are any other questions for me or Kathleen, please let me know before we move on to our interesting cases.
I have one question for Dr.
Mohammed.
Yeah, what's your take about GLP-1 agonists for LADA or new onset type 1 diabetes?
Really depends upon the features of the patient and the C-peptide. If their C-peptide is really low, then I'm probably not using it, although occasionally I do use it in type 1 diabetes off-label as a weight loss aid and as an insulin sensitizer in that respect. Otherwise, if they have at least a normal range C-peptide.
Above 1.
Yeah, if it's above 1, I think it's a great choice, and maybe using in combination with basal insulin, again, depending on, their A1C and how hyperglycemic they are to begin with.
My other question in your practice, how often do you check genetically for MODY? Or you just leave it if they respond to the sulfonylureas or the SGL2 inhibitors? Or how?
So therein lies the challenge, is that it's not widely covered. I've had better luck with referring to, if I strongly suspect this, I've had better luck referring to the geneticist who can navigate through that. And there are also, you can refer them to an endocrinologist, but you can also refer them to clinical trials. For example, University of Chicago has a pretty robust MODY program whereby you can actually submit a saliva sample and get testing. They prefer that you go through insurance first, but if that's not an option, I have done that. And then there are some cases where it's very obvious. So that person who we've put on a sulfonylurea who gets profoundly hypoglycemic is kind of a classic. So that's one of the really, I guess sort of poor person's test for MODY. It doesn't test for all types of MODY, but several of the MODY types are exquisitely sensitive to sulfonylureas.
Thank you.
So we have come to the end of this series, this case-based series on type 2 diabetes. First of all, I want to thank all of you for participating enthusiastically with fantastic cases and comments throughout. I didn't feel as pressed for time this time as I have in past series. I think it's because we spent more time on the cases, and that's often the most interesting part, and less time on the didactics. So I think that was a positive change. I want to, of course, invite all of you to participate in our spring series on weight management, which is a very, very different focus. We're going to focus on social determinants of health, food justice, social justice, et cetera. Issues that I think are really at the forefront in our society right now, but also have a great deal of influence on how we practice medicine and care for these patients as well. So I know that Jesse has a number of things to discuss as we close out our series.